Good afternoon, morning. We're in the middle, I guess. So good lunchtime. My name is Kelly Michelson. I'm so excited to be here and to announce the speaker for this afternoon's talk. We are so fortunate today to have Dr. William Parker here. Dr. Parker is Assistant Professor of Medicine and Public Health Sciences and Assistant Director of the McLean Center at the University of Chicago. He's a pulmonary and critical care physician. He's a clinical medical ethicist and a health sciences researcher with a PhD who studies the allocation of scarce medical resources. In addition to co-directing the University of Chicago Medicine Clinical Medical Ethics Consultation Service, he runs an NIH and Greenwell Foundation funded quantitative bioethics lab focused on absolute scarcity problems where demand greatly exceeds supply, and healthcare systems triage patients for treatments using algorithms. His lab works on deceased donor organ allocation policy, life support triage under crisis standard of care, and the allocation of novel, scarce therapeutics. And he has published in multiple top clinical journals, including JAMA, AJRCCM, JACC, and has also published his normative analysis in the Hastings Center Report, Health Affairs, JAMA Health Forum, and USA Today. He's also written for the Washington Post and the New York Times. We're so excited he's here. He's been recognized with the National Young Investigator Award and the American Society for Clinical Investigation and the American Thoracic Society. So thrilled to have you here, Will. Looking forward to your talk.
Thank you so much, Kelly. It seems like this is on, right? I really appreciate the invitation, and it's so nice to see a bunch of people in person, and collaborators and friends. So this, in terms of my disclosures, the work I'm going to be discussed today is supported by the National Institutes of Health and the Greenwell Foundation, but I have no other conflicts of interest. So my broad objectives are to define the problem we're going to be talking about today, which is crisis standards of care. Then I'm going to lecture about the ethical values for life support allocation in a crisis, the sort of normative framework we have to lean on to try to solve this problem. And then finally finish with 4 active bioethical controversies in this problem and explore them all in detail if we have time. So crisis standards of care, I think, is well encapsulated by this image. This is kind of a quote from a presentation from Bernard Lowe that he gave. This is Memorial Hospital in New Orleans after Hurricane Katrina when the levees broke. As you can see, the hospital is completely flooded, and this is several days after the disaster, and the temperature had risen up into the high 90s, 100 degrees. And it became clear that as the power failed, that the doctors weren't going to be able to take care of all the patients, particularly the critically ill patients who were there, and there was no sign of rescue or help coming. What happened inside this hospital has been a matter of much speculation, book series, now Netflix series, but it clearly was not in accordance with basic bioethical principles. And part of the problem is that all of the healthcare providers and physicians inside didn't have an approach. There was no standard of care for how they should practice in this situation. So in response to this disaster and the H1N1 influenza epidemic, the National Academy of Medicine's developed this concept of crisis standards of care, which is when a disaster is so overwhelming that the healthcare system is unable to achieve sort of normal, basic care for all of its patients. And some patients will suffer and die because they will not receive treatment. And it's an open acknowledgement of that tragedy. So what we're going to do is first start by talking about the ethical values you have to be equipped with to start to approach to think about how to deal with this horrible situation. And it turns out that there is a broader space of this problem beyond just crisis standards of care. Deceased donor organ shortage is an ongoing crisis. every day if a candidate who's placed on the waiting list for deceased donor kidney transplantation today is more likely to die or be delisted than receive a transplant. That's actually one of the main focuses of my lab and ongoing work is to optimize the algorithms for deceased donor kidney allocation and other organ allocation with respect to the ethical principles we're going to talk about. But crisis standards of care is the same dimension, although it's an acute situation or sort of a more pervasive one in the context of a respiratory virus pandemic like COVID. And what's essential here is that demand is vastly exceeding some hard supply limit. So there's some patients who will not be treated. The treatments themselves are unequivocally beneficial. If you have end-stage organ failure, get an organ transplant, your probability of being alive is dramatically higher. And we as a society, for whatever reason, usually very good ones, have decided to centrally control the resource and allocate it algorithmically. And these algorithms are sort of key to the focus point of my lab because these represent a translation of ethical principles into a concrete protocol for allocating treatments to human beings. And that represents taking these normative concepts that we're going to go through one by one and turning them into an operational empirical tool that will actually rank order people for treatment. As you can, hopefully will begin to appreciate by the end of this talk, is an incredibly difficult problem, but it starts with the ethics. So the first idea here is treating people equally. The concept is that in such a crisis standards of care scenario or on the organ transplant waiting list, everyone who has a need for the resource is a human being, and respect for persons would say we should treat them equally. This would be operationalized with potentially a lottery scenario. If you, let's say, had 5 patients show up simultaneously in the emergency room and you had one life support treatment unit like a ventilator. But in reality, you actually end up having a lot of queuing problems like we do in organ allocation. Patients do not arrive at the same time, right? So you end up having to develop queues, and often people conceptualize first come, first served as satisfying treating people equally, right? Well, it turns out that that's only true if everyone's getting in the line at the same point in time, right? And if anyone familiar with the deceased donor kidney allocation system, prior to 2014, your waiting time started when you registered with a transplant center. And it didn't matter how long you had been on dialysis prior to registering, you got no sort of credit for that time served on renal replacement therapy. When this was corrected in late 2014, the disparity in transplantation rates across race ethnicity evaporated essentially overnight. So I think this, when I lecture with the medical students, I pointed to this example as one of the great reversals of structural racism in allocation algorithmic policy, in recent memory, where just by one decision by policymakers could fix a gross inequity in the system. But the point of this example is that first come, first serve is only a fair way to treat people equally if everyone's queue point in the line starts at the same point in their disease state. So maximizing total benefits is the next idea, not maximizing total benefits. Here's the next big set of principles that, all right, if we just allocate randomly, we're not going to save either the most lives or life years. We're not going to get the most treatment benefit on net in total across the population. And so here's the classic example of raised hand. I hope that doesn't mean there's something serious going on. If they can't hear me or see me, if maybe somebody can let me know if that's in the chat. But if saving lives so here's the example: 2 patients, 1 life support unit. Patient on the left has an 80% chance of surviving to discharge. The person on the right has a 40% chance of surviving to discharge. If you just quantify the benefit of the resource, and this is who's alive leaving the hospital, you treat the patient on the left, right? But, well, what if I told you that the patient on the left is 80 years old and therefore has a life expectancy, a maximum life expectancy of 10 years or so, and the patient on the right is 40 and has a life expectancy of an additional 50 years? Then when you do the math and think about what's the total number of life years gained from treatment, you treat the patient on the right, because the total expected life years gain, which is 50 times 40% here, is 20, right? And the patient on the left only has a total potential life year gain of 8. So these are often seen as being in conflict with one another, right? You have to sort of pick, are you going to save lives or life years? I'm going to show you some data later that's not actually empirically true, that often the solution in crisis standards of care that saves the most lives is the one that saves the most life years. And this is where a quantitative bioethics approach is so important, because it can help you focus the debate and where the research should be directed to the relevant issues. And it turns out this isn't one, that the patients who have the highest probability of surviving acute respiratory failure are the youngest one. And any critical care doctor would have told you that without seeing the data I'm going to show you. So we've gone through treating people equally and maximizing total benefits. Hopefully it's already obvious that those are in inherent conflict with another, right? In order to maximize total benefits, you are triaging based on expected benefit, treatment benefit from the resource. That's not treating people equally. Here's another way to not potentially treat people equally, which is that there are certain classes or groups of people who are worse off entering into the allocation game or problem, and we should recognize that and treat them appropriately. The first concept of this is sort of the rule of rescue, that we should triage people who are the sickest first. And this is actually what we sort of do in the ER right now, right? It's like, who comes up to the ICU first? It's the sickest patient. And that's not because that works to actually maximize benefits in that scenario, because everyone's going to get critical care. We're not in a crisis scenario, right? We actually end up maximizing benefits by triaging under normal scenarios, not crisis scenarios, by prioritizing the sickest first. But in a true crisis scenario where you're only going to be able to treat 50% of the patients, that rule of rescue fails. It gives you fewer benefits than a lottery, right? If you prioritize the people with the highest expected probability of death for treatment, you're going to save fewer lives than if you allocate it randomly in a crisis scenario. So that concept sort of falls apart. The rule of rescue falls apart when you're in a true triage scenario, in that some patients are not going to be treated at all. So the next idea in favoring the worse off is that younger people are worse off. So these are people who are either children or earlier in their life. And the idea here is that everybody deserves to play your 9 innings of baseball, right? This is the fair innings concept. And if you develop end-stage organ failure as a teenager, that makes you more worse off than someone who develops end-stage organ failure in their 80s. And it's therefore fair to allocate more resources to the younger person, so everybody gets to play the same amount of baseball. I think it's a very intuitive thing for healthcare workers in the ICU. When you have a young patient, it's sort of like all hands on deck, right? There's sort of this instinct to allocate more resources to younger patients. And this has also been formalized by Norm Daniels, who applies sort of a Rawlsian framework to this problem, and argues that it's fair to treat younger people preferentially in a healthcare system, because everyone will eventually get old and die if you do that, right? So it's prudential lifespan equity. The treatment is unequal across the person's life, but everyone will get to experience it at some point. So therefore, it's what the solution you'd arrive at if you started from behind the veil of ignorance. And so this is a distributional argument. Sorry, I'm going the wrong way. I want to go back, sorry. This is a distributional argument for all healthcare, but when you apply it to algorithmic allocation of absolutely scarce resources, this would have you putting more weight on your thumb on the scale for younger patients. So now the next idea is that, so we've talked about how the young potentially can be viewed as worse off and therefore more deserving of the resource if we're in a crisis standards of care scenario. But what about there's other groups of people in our society who are systematically and structurally disadvantaged, and they have a higher probability of developing end-stage organ failure or acute respiratory failure from COVID because of structural disadvantage? And should we account for that in any way? This is a map on the right, to start with that, from an empirical study we did about the impact of vaccine coverage on subsequent COVID mortality. So if you guys remember, the COVID vaccine allocation occurred in late or early 2021 through the spring, and then we had the alpha waves after that. And it turned out that the areas of the city, everyone's here, it's nice, I don't have to orient anyone to the map because we're in Chicago, but the areas of the city get the greatest amount of vaccine coverage, including where we are right now, had the fewest deaths in the alpha wave. It's funny, sometimes we had difficult estimating some of these statistical models because like nobody died in Lincoln Park or one person dies in Lincoln Park. And so you can't have it's hard to have like a random intercept for that zip code. But where vaccines were distributed, where vaccines were not, rather, is where there were the most deaths in the subsequent waves of the pandemic. And, these neighborhoods that got less access or less vaccine coverage, it wasn't just random or de facto disadvantage. It was actually constructed this by residential racialized segregation. For those of you who haven't looked at mapping inequality, I strongly recommend it. It systematically details how the federal government chose certain neighborhoods for investment and chose certain neighborhoods for disinvestment based explicitly on the race of the people who are living there. And I live kind of right close to that red line right now, and you can see it literally as you drive your car. And so that didn't just happen, it was created. So given this history and given that map, when we're actually deciding where to allocate vaccines, how to allocate life support if we have patients flooding into our hospital at University of Chicago, which is that sort of island on the south side, I can highlight it here. Should we account for the fact that this is how the fire is burning throughout the rest of the city? All right, so that's the ideas about favoring the worse off, the young, or the disadvantaged. Now the last broad concept, last bioethical group, is rewarding social usefulness. Already sounds a little icky, right? But it's actually very common in these algorithms. In kidney allocation, if you have been a prior living kidney donor, you're given the equivalent of 4 years of waiting time on the list. So you're being rewarded for your prior good deed. The next idea, though, is that there's an instrumental value to some people in society who have this multiplier effect, right? They're really powerful CEOs job creators, and we should save their lives because then there's going to be all these beneficial consequences for the rest of society. And I chose a CEO that may not be the most popular to kind of make everyone to think about that and maybe have a reaction against this principle. But if for those of us who got COVID-19 vaccines early in the pandemic, which I assume was a lot of the people in the room, these two ideas were the main driver to justify why healthcare professionals went first. That we had this special value for society, this multiplier effect for others, that I would argue was very imprecisely quantified. And it actually had much more to do with reciprocity than rewarding good deeds. I remember not really thinking I was going to study COVID vaccine allocation, but then I got the invitation to get my second dose before any of my patients had even gotten the option to get one. And it just seems so out of proportion because I was, I was sure as an ICU doctor working in the COVID unit, but I was healthy and I had PPE. And it seemed like that these two principles completely outweighed all of the other ethically relevant ideas in COVID vaccine allocation. And so coming back to the overall view here, and I hope that last anecdote drove this home. These principles are in conflict with one another. You have to develop a multi-principle framework that balances these ideas. If you put all your eggs in any one basket, it's unlikely to be acceptable to all the key stakeholders. And there will often be very powerful objections that people can construct against the algorithm. And this is, of course, I think all this work, this framing was developed by Govind Prasad. And I think that's the most important, in addition from moving this space from the classic beneficence, non-maleficence framework for biomedical ethics and recognizing you need a whole different set of principles to take it on, this acknowledgement that we need to think about all of these ideas. And if we're putting them in an algorithm, we need to justify why, and also think about the consequences for the other ethically relevant principles. All right. So that was a long ethics lecture, but I think it's necessary to set up the current bioethical controversies and crisis standards of care. I think this is a topic where public health and bioethics intersect in a very interesting way. And so I'll tell a story that has to do, as we go through these, with policymakers and reactions in politics that hopefully will be interesting to the non-ethicists in the crowd. So here are the 4 big controversies that I think we need to take on before the next pandemic, before the next crisis unfolds. And the first is that the main way patients would be triaged in order to save the most lives is both biased and very inefficient, and that's the sequential organ failure assessment score. So early in the pandemic, when we were meeting with the Chicago Bioethics Coalition, a great group that Kelly Mickelson put together of bioethicists across the Chicagoland area, we were all in charge or involved with writing down our crisis standards of care protocols for our hospital. Because within Chicago, there was like 15 different plans of various degrees of completeness that these hospitals were putting together. And Gina Pisticello, who was at Rush at the time, said, well, we should just look at this everywhere at the state level and see who has a plan. And it turned out that only about half the states had anything at all, any plan at all for how to direct specifically ventilator allocation during a crisis scenario. And the states that did have plans varied widely. There's a lot in this paper. I strongly encourage you guys to take a look at it. But what I'm going to focus on for this first part is that the sequential organ failure assessment score was the most commonly used protocol. It was in 15 at the time of the state guidelines. And the way this is an example of what one of these crisis standards of care protocols looked like. This one was replicated from the University of Pennsylvania or Pittsburgh joint collaboration that now is, I think, still on, last I checked, on the Pennsylvania website. What it would do is assign patients a score that, it could go up to 8. It's like golf, more points is worse, based on their probability of death as estimated by the SOFA score. So more SOFA score points, higher probability of death. And then another 2 or 4 points based on their prognosis for long-term survival. Interestingly estimated just based on their chronic conditions, not based on their age, which doesn't really make any mathematical sense and never did, but we'll get into that a little bit later on. And there's also considerations here for instrumental value, pregnancy, which is another dimension that has to do with considering that there's 2 potential people whose lives you're saving, right? And what the initial controversies in crisis standards of care focus on is this saving the most life years element, and the idea that this would disadvantage people with disabilities who would be discriminated against by healthcare providers who think because they have a chronic dependency on a ventilator, for example, they just would get 4 points assigned in this score. But I'm going to talk about the SOFA to start. And this is something that no one really questioned early on because it's pervasive throughout the critical care literature. SOFA is a score that was developed in the 90s at a consensus conference that assigns patients points based on their degree of organ system failure. So it's designed to be like a bedside tool. You sort of add up this score and say, is my patient in the ICU getting sicker, worse, or better? Now, a lot of these are actually, to give them credit, based on clinical expertise, turn out to have pretty strong associations with mortality, as I'll show you. As your, for example, from your respiratory system, as your PaO2 to FiO2 ratio, that's a measurement of hypoxemic respiratory failure. As that goes down, you get more points. But the amount of points that you get as you get sicker is arbitrarily assigned, not based on a regression model, not based on any formal statistical relationship between these variables and the probability of death. And that's one of its fundamental problems. The next is that if anybody's actually looked at this cardiovascular or been in an ICU recently, the medications used to treat shock have changed dramatically since this point. Dopamine has been shown to have substantially worse outcomes than norepinephrine and cardiogenic shock, for example, and has really fallen out of favor. So it's out of date both in the components of the score and in terms of the way that the score is constructed, not being based on regression. But having said all those negative things, it works pretty well for patients who are already in the ICU. The people who made this up in the 90s, their clinical instincts about what are the real markers of end stage or of organ failure and multisystem organ failure were pretty solid. And this is the largest validation study of SOFA. And remember, this is in patients who have been admitted to the ICU for 24 to 48 hours. But that's not the situation we're talking about here, right? Remember, we're going back to this thought experiment of 2 patients who've shown up with COVID in the ER. You only have 1 ventilator, and you're calculating their SOFA score in that context. When you do that, the rank ordering ability of SOFA plummets. This is the standard area under the receiver operating curve for the SOFA score and AURC in a large multi-center electronic healthcare record study where they calculated the SOFA score using the worst values 48 hours prior to intubation. Sort of saying, what information would you have at the point in time that you're actually putting the person on the ventilator? If you restrict yourself to that, in contrast to the data I just showed you, which is on patients who are already in the ICU, where enough time has gone by where their SOFA score can change, it has bad accuracy. It's a little bit better than a coin flip, but this paper and others have led Department of Health and Human Services to sort of recommend against SOFA score in triage. But I'll show you, it still remains in all the crisis standards of care. And the other, beyond just being inefficient and not based on modern regression modeling, the SOFA score would exacerbate health inequity if used in a crisis scenario. And the main reason, well, there's 2 main reasons. One, it does not incorporate the age of the patient, which we'll get into in a second. It's just based on these markers of organ failure, and it uses the patient's absolute creatinine value. Not change in creatinine, right? Not urgent need for dialysis from acute kidney injury, their absolute creatinine value. So if someone shows up with chronic kidney disease, for example, and a creatinine of 2.5, they get 2 SOFA points. It's the same as being on pressors for shock in this model. And so for the critical care physicians in the room, hopefully that it seems completely wrong, right? That having being on a low-dose vasoactive confers a much higher mortality than just having chronic kidney disease from critical illness. And this is just because of the way the score was arbitrarily constructed, this consensus conference, not based on a regression model. There's also the issue that certain racial and ethnic populations have higher mean creatinine values for the same estimated glomerular filtration rate. That's more marginal than the fact that chronic kidney disease is not distributed equally throughout our society. And this leads to a statistical bias. In the technical term, as I'll explain in a second, it's a calibration inequity in the score. So this SOFA is not algorithmically fair. It's biased against Black people. And we contributed to this literature, but it's been shown in a bunch of different data sets in similar ways. I'll try to explain exactly what this means with two papers. Starting with the paper on the left, this is what the top is probably easiest to understand. Black patients who have a SOFA score of less than 5 and compare them to white patients with the same SOFA score of less than 5, the Black patients are substantially less likely to die, right? And then as you move up the SOFA score, the gap gets bigger and bigger in terms of Black patients dying less than SOFA score would predict. And that leads to, in a crisis scenario, exclusion from treatment. Because remember, we can't treat everybody. We're rank ordering them, where we're treating the patients with the lowest SOFA score first. If we're doing that and you're excluding some patients, Black patients, who should be included in the treatment group. I'll say that with another way with the paper on the right, which is that if you look at top priority patients in a bunch of different allocation systems, A, B, and C, that's here. So who's the top priority for treatment? The Black patients in that group are substantially less likely to die. And this means that there are other Black patients who should be in that group, and this odds ratio should be 1. So this is a form of not assigning the correct predicted survival to a particular racial and ethnic group because of not having a regression model, because of a built-in algorithmic bias in SOFA. We showed this in patients with COVID-19. Most of those papers were using a general ICU population in a collaboration with Kelly and Yuan Lo from the University, or from Northwestern. So this is a mixed population of both patients from the University of Chicago and Northwestern who were admitted with COVID-19 and respiratory failure requiring mechanical ventilation. We had 1,000 patients. We would draw 2 random patients from the sample, apply the triage rules, and then we assume the patients who did not get assigned a ventilator would die. But the patient who did get a ventilator, we observed their real outcome in the real data set. And if they survived, then we counted that as a win for the allocation system. And so what I'm going to show you here is data from a 50% scarcity situation. So you can only treat half the patients. So the best the algorithm can do is 50%. But a more efficient algorithm, or a maximally efficient algorithm, might be able to achieve 50% survival if it's able to identify all the survivors it can up to the point of scarcity. But the algorithms are not that good. And it turns out that SOFA only marginally increased. It was like 1%, the overall survivor of the population. And it did so at the expense of creating large disparities against patients who were Black. They received higher SOFA scores than they should, and they had a lower chance of being allocated life support in the simulation, and were more likely to die in the crisis scenario. So I know that's complicated in multiple steps, but it's an example of how an algorithm, by not being well calibrated across race ethnicity groups, can lead to lower allocation of critical healthcare resources, and in this simulated crisis scenario, higher rates of death without any greater benefits to the society overall. And so despite these two big problems, that SOFA is not a well-designed triage score. It wasn't designed to be a triage score, and it doesn't perform well in a triage situation. And it would, as a statistical bias against Black people, it's even more dominant in crisis standards of care protocols across the country. So remember that first map I showed you from Gina's early study. Now a couple of years have gone by, and some states have come online with plans. And there's a heavy reliance in SOFA, or either it's like the only thing or most of the score in 86% of the plans. And so this is, if we had another pandemic tomorrow, this is what people are supposed to use. This score that I've just hopefully convinced you has deep problems. So don't worry, we're trying to work on making a better one with the grant, but that's I think it's a big problem that right now this would be plan A. So to conclude about the first bioethical controversy, SOFA is an outdated severity of illness score. It's designed for patients who are already in the ICU and not designed for triage. When you apply it as a triage score, it has a very low ability to rank order patients by survival and a statistical bias against Black patients because of higher rates of chronic kidney disease, which makes it even more inaccurate. So debiasing SOFA score and revising it is a way to both save more lives and reduce inequity. And that's one of our main aims of our current R1 project. All right, so that's problem number one. I think the most, well, they're all substantial controversies, but second one is how can age be used in these crisis standards of care, or if at all? It turns out, as I mentioned earlier, there are very deep and well-constructed philosophical arguments for prioritizing younger people. The way that is operationalized in the organ allocation system is categorical priority for children, right, as this vulnerable class that deserves that we need for society to function, early access to organ allocation. There's not as much of this continuous advantage for younger people in organ allocation, but it's there. But despite these ideas, which, and I mentioned earlier about prudential lifespan equity, to remind everyone, is this concept that it's okay to treat younger people preferentially when you have an allocation algorithm for healthcare resources. These ideas are out there. They infiltrate they're involved and they're in the minds of some of these people who are writing down these crisis standards of care plans. And some of the early protocols actually put explicit weight on younger people. So this is from Utah. And as you can see here, estimated survival, which is kind of the maximizing benefits idea, right, is on the bottom. And then here, they're explicitly valuing the lives of younger people greater in the algorithm. So it's not necessarily like incredibly well supported by a deep normative analysis, but the idea is in there. This got a lot of attention from the Office of Civil Rights in the Department of Health and Human Services, which went after crisis standards of care throughout the country and asked states, this wasn't actually ever litigated in court, but sort of strongly encouraged states to remove any mention of either age or disability status. And the concept here is that valuing certain people's lives based on these conditions that they can't change, like their disability status, is inconsistent with U.S. law and also violates this idea of treating people equally, and insisted that people with disabilities are evaluated based on their actual mortality risk. And age just kind of got lumped in here along with the disability criticism, which I think I'll hopefully show you was a little problematic. Because what states did in response to that was essentially say they've changed their crisis standards of care, they've removed age. A lot of states haven't seemed to replace it with anything in particular, but I think we could assume that it would just be a SOFA score-based system. And age would in no way be involved with their crisis standards of care protocol. And I think it's important to remind ourselves that there are two reasons to use age. One is that the value of younger lives is sort of higher, or there's a moral argument for prioritizing them. That's rejected for political reasons currently in the US, in the crisis standards of care scenario anyway. And so we can certainly have a debate about whether that was the right decision. But the other thing to remember is that age is a strong independent predictor of short-term survival from acute respiratory failure or any critical illness. And so if your goal is to save the most lives, an algorithm that incorporates age will do that if designed statistically to achieve that end. And that brings us back to this empirical reality, right, in critical illness, that the solution that saves the most lives is the one that saves the most life years and value or prioritizes the younger over the old. And this is some data that we're having a little trouble getting published because there's in the critical care world, people really like SOFA, but that shows, I'll walk you through this quickly. The x-axis here is age and the y-axis is life support mortality. So critical illness in general critical illness population that's on receiving a ventilator, high flow nasal cannula, or vasoactive medications for shock. And the black bars are observed mortality. And as people get older, they're more likely to die. Not surprising at all, right? But their SOFA scores, sort of by construction in this cohort, are pretty similar. And so their predicted mortality by SOFA in the red is the same. But if you build a regression model that includes both SOFA score and age, you're able to recapture the discriminate between survivors or non-survivors at a much higher rate and match observed and predicted mortality. So this is an example of how SOFA is partially inefficient because it doesn't include age as a variable. And it's less good at saving lives because it's ignoring this critical feature, clinical variable that we use in clinical prediction all the time. So age is only one variable among many, or to save the most lives is a robust justification and is an accepted practice in healthcare allocation algorithms and other contexts. So I would argue that removing age from life support allocation is a form of anti-young ageism. It's actually prioritizing the elderly for scarce resources over younger people who are more likely to survive. And I also think that these concepts like fair and experiential lifespan, equity, saving the most life years actually have broad appeal to a lot of people. And it's problematic that all the current state crisis standards of care protocols ignore these concepts. And I think this is something that the fact that these ideas are out here at least support the inclusion of using age as one variable among many to save the most lives. All right, in the last 10 minutes or so, I'll try to get through the last two big active bioethical controversies. And the next one is the unequal distribution of the pandemic that I mentioned earlier. This is the striking article in Chicago about deaths in Chicago in the first wave of the COVID pandemic in the spring of 2020, where out of the first 270 people to die, 2/3 were self-identified as African American and concentrated sort of exclusively in the south and west sides of the city. This continued, as I mentioned earlier, throughout the pandemic, even after we had vaccines available. And so given that context, now we have to think about when patients are arriving in a crisis scenario to a hospital and the hospital's overwhelmed, we've blown past our capacity to treat. How do we think about that map? How do we incorporate it into our decision-making? And I can think of sort of 4 different big ways to approach this. First is the concept of demographic parity, which is that across a protected characteristic like race or ethnicity, we need to ensure equal access. And this is also called the independent statistical criterion for algorithmic fairness, which is that everybody has the same chance of receiving. The y-axis here is actually survival, but it was achieved through random allocation because each racial and ethnic group actually has the same survival on average. And the problem with demographic parity in the allocation of scarce resources is that what if there are particular characteristics that are associated with the protected characteristic that are also really associated with the outcome you care about, right? So going for a purely random allocation often will not maximize the most benefits. So then the next idea is to prevent the algorithm from making the inequity worse that you're allocating the resource for. And this is the formal principle here that I think is most relevant is one called sufficiency, which is that the score means the same thing across for each racial and ethnic group. This example here is from this FAIR machine learning book. I forgot to put the citation. It's excellent. And what it's showing is that as the predicted value on the x-axis goes up, the observed value goes up right on the 50-50 line. It's incredibly well calibrated score. This is also operationalized as like the Breyer score for those familiar with that concept. And it's the same across racial and ethnic groups. This is what SOFA does not satisfy, right? So a Black patient with a SOFA score of 5 has a lower predicted mortality. So for SOFA, the line would be like here for Black patients. And that explains why the system is biased and unfair against them. This ensures that the system will be relatively efficient in identifying survivors, right? A really well-calibrated score is one that's usually very accurate in terms of identifying patients who will benefit from the resource. But it also does not guarantee demographic parity, right? It allows for differences in allocation across race and ethnicity, which may be appropriate. So whether sufficiency or demographic parity or equal allocation is the right idea depends on the context. I think in this one, sufficiency makes more sense. So SOFA would violate non-discrimination. It's a biased algorithm, specifically biased by failing this calibration parity test. So how to address this in general, how to debias the SOFA score or go further. It turns out that you can't use someone's race or ethnicity itself to fix the problem when it occurs. So the example on the left is from the state of Minnesota developed an algorithm to identify patients at highest risk of death from COVID-19 to allocate scarce monoclonal antibodies. So the situation is sort of reversed here. You want to identify patients at highest risk to prioritize them for treatment with monoclonal antibodies, which prevent progression to severe COVID. And when they included like this BIPOC term, so basically anybody who is non-white in the regression model, even controlling for all the differences in age and comorbidities, patients who identified as BIPOC were more likely to die. So they tried to explicitly allocate monoclonal antibodies using race and ethnicity. And this sort of failed the political test. It was taken up by right-wing people to demagogues who used it and misrepresented it in horrible ways for political gain. And the state backed off and just took out the BIPOC term from their algorithm. But I think using race ethnicity explicitly to allocate scarce resources in algorithms may end up failing constitutional tests. Everyone's probably thinking about affirmative action, right? And so we can't use that. And there's also this identification problem too of like, are you racializing people into groups based on their physical characteristics? If certain people know that certain groups get priority access, why wouldn't everyone just identify as that group? So we can't do that. But and so what states have tried to do, who are concerned about this, particularly the state of Colorado, is to modify the SOFA score and just sort of subtract some points from the renal component. But as many of us are working on right now, including Kathy Gao, who's collaborating with me in the room, it's best to probably just make a whole new score, explicitly designed for triage, that's based on a regression model that actually associates these variables, which are important variables, except for the pressors, they're very old, with survival. So that's what we're working on. But fixing SOFA does not, remember, fixing SOFA would not make the map worse, not make the structural inequity worse. Maybe we should do something more to correct the map. And this has been proposed a couple of different times, which is the idea that we have validated indices which correlate with structural disadvantage, place-based disadvantage indices that predict where patients are going to die in crisis scenarios. And we could put that directly into the score. So this is Doug White and Bernie Lowe's concept of promoting equity by subtracting points. Remember, it's like golf, you want a lower score from the triage score for patients if they're in an ADI 8, 9, or 10 decile community. And, you know, this is the vignette from their paper. Here's 2 patients, right? The patient on the right has a higher predicted hospital mortality, but is from a disadvantaged neighborhood. So under the, you know, the White-Lowe proposal, the patient on the right would be prioritized. They've operationalized this in the allocation of monoclonal antibodies in the Pittsburgh network, where patients who lived in high ADI neighborhoods were twice as likely to win the lottery. So this has actually been done in real life, granted not in a crisis scenario, but in one where allocating monoclonal antibodies. And Harold Schmidt from Penn has also proposed this in the Oregon Health Authority Crisis Standards of Care, where patients who would get more chances in a weighted lottery based on their degree of disadvantage. And this is something we're currently working on, sort of commissioned to help simulate this for Oregon. But this idea is not without its critics, right? So this is the sort of reply to the initial White-Lowe proposal to prioritize patients from disadvantaged neighborhoods for life support allocation in a crisis. They criticize this sort of narrative description of the whole patient as invoking social, non-medical factors in triage, right? They really didn't like the fact that the person's race and ethnicity in both stems was explicitly identified, right? Perhaps to make the person on the right more sympathetic. And they also say that it's totally appropriate to direct large-scale public health interventions like vaccines and testing using ADI, but not at the point of triaging a critical life-saving resource. There's also criticisms that ADI is not granular enough. So this is the rich guy buys a condo in the disadvantaged neighborhood type of criticism. And this is the active back and forth on this concept. I think there's the best way to engage these ideas is to actually quantitatively assess them with simulation and empirical studies. And that's what we're working on in the lab. Make it clear what the explicit trade-offs are. And if we're going to include place in triage, make it sort of explicitly so based on a specific ethical objective. And then the last idea is that, we should try to allocate additional resources to correct disparities in the current crisis and prior wrongs, right? This is the most controversial. And people have argued it's not the right time to try to fix historical injustices that have been perpetrated against marginalized communities when allocating life support. But that is distinct from attempts to correct present-day structural inequity, attempts to make that map of COVID deaths more equal. So in conclusion, discriminatory triage scores such as SOFA, I think are on their face wrong and should be avoided to prevent the exacerbation of health inequity. You can only get true demographic parity across sensitive attributes like race, ethnicity with a lottery. And I think that there is a role for place-based disadvantages indices in crisis standards of care, but I don't think we know yet what the weight should be. And I see them at the top of the hour, so I'll just have to tease you with the last one, withdrawing versus withholding. And it's basically that the entire thought experiment of 4 patients and 1 ventilator is ridiculous and not at all representing reality. And reality would be way more complicated, right? Patients would be coming in the ER steadily. I don't know if anyone has worked in the COVID unit during one of the upswings of an exponential growth, where it was like 2 patients on day 1, 4 patients on day 2, 8 patients on day 3, going up, this terror of the ICU filling up until it breaks. And that's what we're actually trying to empirically assess, because I think the decision to withdraw life support on someone who's not doing well is actually going to be where all the action is. And with that, I want to respect everyone's time, but point out that we're achieving a lot of these goals with this really fun multi-center collaboration, and happy to talk more about the technical details of the clinical informatics project associated with this after the talk. And with that, I just want to thank my mentors and thank you so much to Kelly for the invitation and your attention. Thanks.